So my objectives are to review the history and basics of monoclonal antibodies, to identify targets and mechanisms of various mAbs, to discuss some target-based toxicities of classes of monoclonal antibodies, and in the end, we're going to summarize CAR-T manufacturing, the FDA available products, as well as some toxicities and management strategies. So very basically, for monoclonal antibodies, this should probably be a review for everyone, but they were evolution from research tools all the way now to kind of basics of pharmaceutical agents or pharmaceutical chemotherapy practices over the past few decades. They come with a variable and a constant region that can be altered. They have light and heavy chains, as we all remember, and they have complementary determining regions within their structures. I like to think of monoclonal antibodies in the mechanisms by which they elicit their function. They have several highly effective tumoricidal functions. They can serve as both receptors or ligand binding, so antagonism or signaling. So here in the graphic on the left-hand side with antagonism, you can have your monoclonal antibody bind to a receptor and block what the endogenous ligand should be. You could have it function as the signaling, where it is actually serving as that ligand to trigger that cascading pathway. You could have it serve as complement-mediated cytotoxicity, so your monoclonal antibody binding to a receptor leading to the activation of the complement cascade. Or you could have an antibody functioning to drive cell-mediated cytotoxicity. Here in the graphic example, you can have those mAbs leading to T-cell activation and cell lysis and cell death. And then we'll also talk about it a little later, but you can also have these monoclonal antibodies serve as almost a Trojan horse, bringing in other molecules when we have drug antibody conjugates that we'll discuss a little later. Back to the basics of monoclonal antibodies, we have kind of a cheat sheet for nomenclature, looking at the structures of these monoclonal antibodies and what type of mAb they are, aka how much human protein versus non-human protein is expressed in them. Going way back to some of the oldest mAbs, if they are murine or almost entirely non-human amino acids, their nomenclature has the O as the primary nomenclature for those structures. More commonly, we know of things like rituximab with XI, where you have chimeric proteins, where the human C regions exist, but you do have non-human V regions for proteins expressing. And then as you go further down the table, you have mAbs that are more human or almost entirely human, and that does portend to some of their toxicities, such as risk of infusion-related toxicities, lessen as you become more humanized within your protein structure. Getting actually into some of the monoclonal antibodies, we'll start with some classes or agents that are directed towards certain receptors. The old classic is, of course, CD20 targeted monoclonal antibodies, and particularly rituximab, but others in the class, obinutuzumab as well as ofatumumab, all of these are monoclonal antibodies that bind and are directed against CD20, which is highly expressed on B-cell lymphocytes. These monoclonal antibodies bind to antigens, activating complement-dependent and antibody-dependent B-cell cytotoxicity. And they can also activate neutrophils and produce free oxygen radicals. They bind structurally to different sites. So here's a nice graphical depiction of CD20 and some binding sites for rituximab as well as ofatumumab. You can see that they do bind to different structures within that actual target. Pharmacokinetically, you can see B-cell depletion for the use of these products for months and months. So it's certainly a consideration for your patients receiving CD20 targeted therapies. And if you just look at structural half-lives, they do hang around quite a bit longer than what you would classically expect for other cytotoxic chemotherapies. When you talk about indications, it's not really a fair question because, of course, rituximab has lots of FDA-approved indications, but even more so, many, many, many off-label indications that we use in clinical practice. Whereas with the kind of second-generation CD20 targeted therapies, these are a little more restrictive with regard to their FDA-approved indications. Dosing of these CD20 directed therapies do vary as well. The classic rituximab is 375 milligrams per meter squared every 7 days, or even in some regimens every 28 days. Whereas obinutuzumab, which is the other one that we classically use here at UW Health, the dosing looks a little bit different. You actually have a very small dose that you do as kind of a pseudo test dose on day 1. You do a 900 milligram day 2 once they have good tolerability to the lower dose. And then you see that you have a load of 1,000 milligrams on days 8 and 15. And beyond cycle 2, you have 1,000 milligrams every 28 days. Toxicities associated with CD20-directed monoclonal antibodies. There are black box warnings for infusion-related reactions, particularly with rituximab, severe mucocutaneous reactions with rituximab, hepatitis B reactivation, another reason why in all of our treatment plans they have hepatitis B labs so that we can identify those patients who are at risk for reactivation. And then it also includes a black box warning for PML, or progressive multifocal leukoencephalopathy. We do have other adverse events, as you all are almost certainly aware, including nausea, vomiting, and diarrhea, dizziness, pruritus, and infusion-related reactions. These medications should be provided with supportive care, including at least Tylenol and Benadryl. And there are some drug interactions that you should consider, including considering immunosuppressants and live vaccines. Sticking with our class-based agents and toxicities, I want to talk about the HER2-directed therapies, referring specifically to pertuzumab as well as the classic trastuzumab. These bind to extracellular domains of HER2. They're mediated by antibody-dependent cellular cytotoxicity. They inhibit the proliferation of cells that overexpress HER2. And then these are, as you can see within the structures, they target, again, different areas of the HER2 domain, showing that they have different functions or at least different binding affinities and structures. Pertuzumab and trastuzumab may be administered in any order between the two products, as our treatment plan kind of specifies, but they should be given prior to your cytotoxic docetaxel. We do have indications here. Breast, of course, for both. Trastuzumab has an indication for HER2-positive gastric cancer. I have the dosing here on the slide. And then, of course, looking down importantly at the black box warnings for these products, cardiotoxicity, teratogenicity, and infusion-related reactions, as well as pulmonary toxicity, are specified as black box warnings. Trastuzumab has all 4 of those. We do have quite a high incidence of rash associated, as well as GI toxicities, particularly when these products are used in combination at the same time. So it's one of those things that you really need to work with your patients to make sure that they understand what those toxicities may look like. Of course, we don't have just mAbs that are targeting HER2. In contemporary practice, we now have HER2 plus products. Adotrastuzumab emtansine is a antibody drug conjugate, and you can see here in the slide you have your monoclonal antibody that targets HER2. You've got a linker that connects it to a microtubular inhibitor, or DM1, here in the structure. Dosing is 3.6 milligrams per kilo every 21 days. These are indicated for HER2-positive disease with residual disease after trastuzumab, or HER2-positive breast cancer patients after trastuzumab, so falling after those trastuzumab patients. We do have toxicities, including hepatotoxicity as a black box warning. And basically for the toxicities, you see trastuzumab-related toxicities, but more standard or cytotoxic chemotherapy side effects, such as anemia and thrombocytopenia, and those count suppressions that you would classically see with cytotoxicity. Because again, this is directed monoclonal antibody delivery of a chemotherapeutic agent, but you still do see some systemic toxicities associated with that. And then the most recent, famtrastuzumab deruxtecan. This is basically, again, a monoclonal antibody with a drug linker linking to a topoisomerase I inhibitor in this case. The dosing's here on the slide, 5.4 milligrams per kilo every 21 days. This is indicated for HER2-positive breast after 2 previous HER2 product, aka trastuzumab, and the previous agent, though there was some recent data comparing these last two drug antibody conjugates that was out last week that may indicate that this product is potentially superior to the prior product. So that may be something that changes our paradigm for dosing in HER2-positive metastatic breast cancer, something to follow going forward. But back to our content here. Black box warning for this product includes interstitial lung disease. And again, we're talking more about some of these classical cytotoxicity chemotherapy side effects. And this one includes a pre-medication required for a significant nausea risk. Our next class of targets include the EGFR inhibitors. If you spend any time in the GI clinic, you'll know about cetuximab and panitumumab. These products bind to EGFR and can competitively inhibit the binding of EGF and other ligands. They block the phosphorylation and activation of the tyrosine kinases, leading to inhibition of cell survival and growth. And then this signal transduction results in a RAS wild-type activation, whereas, as importantly noted here, mutant cells are unaffected by these products. So these should only be used for those who are identified as wild-type. We have our indications, our FDA-approved indications here, colorectal cancer for both panitumumab as well as cetuximab. And cetuximab also holds a head and neck and squamous cell FDA-approved indications. This slide dosing includes what is approved for all indications. So cetuximab classically has had a upfront heavier dose, 400 milligrams per meter squared as a loading dose, and then 250 weekly. Although there are some indications that now have a 500 milligram per meter squared every 2-week dosing regimen to make it a little more convenient, and follow with panitumumab 6 milligrams per kilo IV every 14 days. There is some considerations with the EGFR products that are important to know. The EGFR inhibitors do have some black box warnings for cetuximab, especially for infusion-related reactions as well as cardiopulmonary arrest, and panitumumab with the dermatologic toxicities. This is one of those weird classes of medications. Some of you may know about this, but in certain regions of the U.S., the infusion-related reactions of cetuximab are much higher. This is classically in like the West Virginia kind of Appalachia area, where rates of infusion-related reactions are greater than 2-fold higher than usually the rest of the U.S. population. There's a lot of postulated reasons for why this population has a higher risk of infusion-related reactions, but it's one of those things that are really interesting, especially from a pharmacist's perspective, but it's certainly something that to talk with your patients about because it is such an odd kind of toxicity. As you can see on the slide, common toxicities for these EGFR inhibitors include an acneiform rash. This is quite a prominent one here, but there are quite a few things that we include in our treatment plans here at UW Health to help with that, whether it's doxycycline prevention, whether it's moisturizers, but this is a toxicity that a lot of patients find particularly problematic and can certainly limit quality of life in our patients. There are other ones here, including electrolyte imbalances as well as dyspnea and cough that are problematic for our folks as well. This is an area of practice that we don't generally see a lot of comparator trials that are head-to-head, but we happen in this case to have a head-to-head trial of these two agents. It was referred to as the ASPECT trial in those with metastatic colorectal cancer. They straight up compared panitumumab to cetuximab in a non-inferior process, and they identified that panitumumab from an OS perspective was non-inferior. They had more skin toxicity in grade 3 to 4 in the panitumumab arm, but they had much less infusion-related reactions in the panitumumab arm, as we talked about earlier. When you look at your nomenclature with the XI and the chimeric monoclonal antibodies, you expect them to have a less amount of humanized protein and therefore a higher risk for infusion-related reactions than you would with a humanized U-based nomenclature for panitumumab. So this is a really nice description of that in clinical practice. Moving on to the VEGF inhibitors, we've got kind of 3 in the class, or at least 3 prominent ones in the class. You have bevacizumab, ramucirumab, and zivaflibercept. Bevacizumab binds and neutralizes VEGF, so you find it here actually going after the ligand to the VEGF inhibitor or VEGF receptors. Ramucirumab binds to a different set of that, actually binding to the receptors, and aflibercept actually acts as a decoy receptor going against these VEGF receptors within the cell. This leads to the inhibition of cell proliferation, angiogenesis, as well as microvascular growth, particularly towards malignant cells. We do have lots of FDA-approved indications for this class of medications, and it's kind of specified here on the cell, but of course, looking at package inserts or LexiComp are going to be more comprehensive for you. And we have the dosing on the slide here as well. Bevacizumab, since it's kind of our classic 5 to 15 milligrams per kilo IV every 2 to 3 weeks, depending upon your indication or your treatment plan. VEGF, we just wanted to talk briefly about it because it is such a kind of ubiquitous ligand that affects a lot of different things. So going from left to right on the slide here, VEGF has effects on blood pressure. It has effects on kidney function. It has effects on the coagulation cascade as well as angiogenesis, as well as vascular hemostasis, immunomodulation, bone marrow function, and thyroid function. So anytime that you're modifying or modulating this for effect, you can expect a lot of different toxicities associated with that. When you look at just simply the black box warnings for VEGF inhibitors, including bevacizumab, GI perforation, severe or fatal wound dehiscence and hemorrhages, and particularly for surgery and wound healing impairment, this is a class of medications that you want to ensure that you understand when the last dose was for these products, ensuring that you're within a safe window to potentially have issues with surgeries and wound dehiscences and things like that. Other toxicities, again, really tying well with what VEGF affects, but you're looking at hypertension, you're looking at blood clots and GI toxicity, as well as renal issues and things like proteinuria. So we have treatment plan builds that are pretty comprehensive in their management and understanding of, make sure that you're checking blood pressures for these folks, make sure you're looking at a UA for these folks to ensure that these are safe products to continue administering. Now we'll move on to some kind of one-off targeted products, which is kind of the vast majority of our MAB discussion today. Brentuximab vedotin is a drug antibody conjugate against CD30. This is classically linked as a MMAE microtubule disrupting agent with a linker to a IgG1 antibody that targets CD30. This drug antibody conjugate will bind to the cell, forming a complex. That complex is internalized by the cell, where you'll have the cleaver will be cleaved, releasing the microtubule disrupting MMAE, leading to cell cycle arrest in the G2 or M phase and eventually cell apoptosis. The FDA-approved indications here are anaplastic large cell lymphoma, Hodgkin's lymphoma, Hodgkin's after autotransplant, as well as CD30 positive mycosis fungoides and peripheral T-cell lymphoma. Dosings on the slide, 1.8 milligrams per kilo every 21 days, and you do have some dose adjustments here for severe impairment of hepatic function. Pharmacokinetically, I added on here your antibody drug conjugates. Time to peak is right at the end of the infusion, but the release of the actual microtubule disrupting agent peaks at about 1 to 3 days post-infusion. And then the terminal half-life for the product is out to a week. Toxicities include, for a black box warning, progressive multifocal leukoencephalopathy, whereas with a lot of other toxicities here, we're talking about things like fatigue, particularly sensory neuropathy is a limiting toxicity for patients. And then you get into some of the old classical toxicities like count suppression. Some drug interactions include, again, with any of these things that include cytotoxicity, you're worried about immunosuppressants in live vaccines, but any strong 3A4 inducers and inhibitors may be problematic for these folks. So just kind of reach out to your clinical pharmacist if you have questions or concerns about that. Moving on to a very interesting case of a drug antibody conjugate is gemtuzumab azogomycin. Again, a drug antibody conjugate targeting MAB of CD33. a chalekiamycin derivative, which is cytotoxic, and then, of course, your protease cleavable linker. This binds to CD33, again, internalizing that complex, releasing the chalekiamycin, and then causing DNA binding and double-strand breaks and cell arrest and apoptosis. Here's, again, your structure if you're terribly interested in the chalekiamycin structure. FDA-approved indications currently include newly diagnosed CD33 positive AML, relapsed refractory CD33 positive AML, as well as we use it for acute promyelocytic leukemia as well. The dosing is included here for your typical indications for combination with 7 and 3 or as monotherapy as well. And then something particularly notable here is hepatic dosing, so you want to hold that for LFT abnormalities, and we'll talk a little bit about the VOD risk here in a moment. I've included the pharmacokinetic half-life just kind of for your reference. This is, as I mentioned, a very interesting drug to discuss because it was actually originally approved way back in 2000, which is very old for some of these drug-antibody conjugates. It was actually withdrawn from the market back in 2010 and was reapproved by the FDA in 2017. And in the meantime, after it was approved, this is a really good example of kind of phase 4 clinical trials. They found in those surveillance trials after FDA approval, they actually found an increased risk and mortality in those folks who were receiving this product as compared to not receiving this product, which led to it being pulled from the market. There was particularly a high risk in hepatotoxicity, veno-occlusive disease of the liver. Folks who went on to stem cell transplant also had a higher risk of veno-occlusive disease, which if you've spent much time in stem cell transplant, you know is one of those toxicities we certainly try and avoid. So this is one of those drugs that was kind of the poster child for those surveillance studies and was recently reapproved and put back on the market in 2017. I would say that we don't do an awful lot of it here at UW Health, but we certainly do, 3 or 4 patients a year getting these products going forward. There are some other toxicities to discuss. Cardiotoxicity is a concern with these patients. And as you've seen, a lot of concerns for nausea and hemorrhage and fevers and all of these things that you would expect for folks that are undergoing AML induction or consolidation. Next, we'll transition to some of the multiple myeloma monoclonal antibodies. We've got 4 to discuss, 3 on this slide. The poster child for myeloma mAbs at this point is daratumumab. Daratumumab binds to CD38, which is highly expressed in myeloma cells. It induces direct apoptosis via cross-linking, immune-mediated lysis via complement, as well as antibody-dependent cellular toxicity and phagocytosis. So it really covers kind of the spectrum of what a monoclonal antibody can do for you with regard to cell kill. Isatuximab is kind of its cousin. It also targets CD38, and it does via cell-mediated cytotoxicity, complement, as well as phagocytosis. And elotuzumab is sort of the distant cousin, where it's targeting against a different expression within myeloma, which is the SLAMF7. It actually activates NK cells through SLAMF7 activation and mediates antibody-dependent cellular toxicity through the CD16 pathway. I've included here on the slide your dosing. Daratumumab, 16 mg per kilo weekly. This is a drug that's FDA approved for newly diagnosed folks in the transplant-ineligible quadruplet, as well as in the relapse refractory setting in combination with other products, as well as a single agent. So it does have single agent efficacy, which is not something that you will see in something like elotuzumab. Isatuximab, 10 per kilo weekly in the relapse refractory setting, and ELO, again, in combination with other products in the relapse refractory setting. Daratumumab was originally a product that was approved as a IV infusion, but as you might know at this point, the product, the Darzalex FastPro product, which is an administration, subcutaneously, has kind of revolutionized how we administer this product. It used to be a product that had a hang time of 8+ hours for its first dose in clinic, and now we've kind of transitioned to this Darzalex FastPro product that has a administration, subcutaneously with like a 2-hour observation time frame making this much more convenient for patients as well as providers. So it's one of those things where we've gotten more clever in how we administer these products to make everyone's life a little bit easier. Here's a classification of the toxicities that you would expect for some of these products. Daratumumab is kind of unique, again, because it's the one that we use most readily, but also it includes this interference with cross-matching and RBC antibody screening. So anyone who's received daratumumab currently or in the recent past needs to be careful about their cross-matching and RBC compatibility. The other toxicities are here, including back pain and pyrexia, as well as fatigue, so kind of common stuff. Isatuximab has a little more count suppression associated with it, anemia in 99% of patients, that's a big number. And elotuzumab toxicities include a lot more cardiovascular toxicities that you don't see with the other products, likely owing to its different target of SLAMF7 and kind of how it goes about its cytotoxicity. As we mentioned, a lot of these products are going to have issues with regard to immune administration. So all of these products should have supportive care, Tylenol, Benadryl, and at least steroids as part of their administration, just for infusion-related reaction purposes. The last monoclonal antibody for multiple myeloma I wanted to talk about was the most recently FDA approved. This is belantamab mafodotin. This was a drug that we saw a lot in our clinical trials on the CRU, and now that it's FDA approved, I think we're seeing quite a bit of it as well. It does have a novel mechanism in which it has a drug antibody conjugate, which we've seen quite a bit today. But it's targeting a receptor BCMA, or B-cell maturation antigen. So we do have a novel target here. So, your patients who have progressed through CD38 targeted therapy or SLAMF7 targeted therapy, you have a new mechanism here, or at least a new drug target. It is currently approved in the relapse and refractory setting, of course. Dosing is included on the slide, 2.5 mg/kg, absolute body weight once every cycle, every 21 days. But the most important thing to talk about with belantamab is the toxicities. As you can see on the bottom here, a lot of visual issues. Blurred vision in 22% of folks, decreased visual acuity in 53% of folks, epithelial keratopathy in 71% of folks. A lot of visual issues. So as associated with that, ophthalmologic evaluations, including a visual acuity and a slit lamp exam, are required at baseline as well as prior to every dose of therapy and for any worsening symptoms. So every cycle of therapy, these folks need to have a visual acuity checked. They need to use preservative-free lubricant eye drops and avoid contact lenses if at all possible. And there are specific and very spelled out dosing recommendations for corneal toxicities that these patients may experience. So it's kind of a weird drug that has a novel mechanism of action that comes with a lot of toxicities here. And with a nice point out there, does have a big significant REMS process associated with it. But please remember BCMA as a target here, because we will discuss it a little further when we get to our CAR T-cell section. Moving on to our next drug, polatuzumab vedotin. Again, we're looking at another drug antibody conjugate here. With MMAE, again, one of those drug conjugates that we've used in several other agents. This is FDA approved for the relapsed refractory setting for diffuse large B-cell lymphoma. It's approved in combination with bendamustine and rituximab, though I have seen clinically a decent amount of this drug used as single agents, dropping these two agents in combination. Dosing is 1.8 mg/kg every 21 days. This has toxicities including particularly peripheral neuropathy and hypocalcemia, some things that you haven't really seen a decent amount of in these folks. And again, with MMAE, you see a decent amount of liver toxicity here in your toxicity profile. Sacituzumab is another antibody drug conjugate. So we're looking at a antitrophoblast cell surface antigen 2 or a TROP2 monoclonal antibody, including a topoisomerase 1 inhibitor, SN38, with, of course, our linker that we see with all of these drug antibody conjugates. This is FDA approved currently for metastatic and refractory triple-negative breast cancer. This is 10 mg per kilo, days 1 and 8 of every 21-day cycle. And we're looking here at your toxicities, particularly at some of those classical chemo, count suppression, liver toxicity here, as well as some of those MAB-based hypersensitivity reactions that you'll see. So again, the best of both worlds with regard to toxicities. Working our way through the rest of the drug antibody conjugates here, enfortumab vedotin is a antibody drug conjugate that is anti-nectin IgG1, which is found on cell surfaces, particularly highly expressed in urothelial, breast, gastric, and lung cancers. And this is drug antibody conjugated to a MMAE, which again, we've seen in several of our agents. This is FDA approved for locally advanced and metastatic urothelial cancers, 1.25 mg per kilo, days 1, 8, and 15. And again, once again, I feel like a broken record here, but I'm giving you a lot of these toxicities that are associated with classical chemotherapy or MMAE with your bone marrow suppression. But interestingly, with this product, you have a very high risk of skin reactions. Up to half of folks, including Steven Johnson's and toxic epidermal necrolysis. And then you have some GI toxicities, including up to moderately emetogenic for these folks. And you have, again, some ocular toxicities with this product as well. So you're worried about things like dry eye. So this is a drug that has some really interesting toxicity profiles that, again, patients need to be well addressed to before starting therapies. And one of my favorite and most interesting monoclonal antibodies here is dinutuximab. This is particularly going to be seen for the pediatric folks. But as a background here, it binds to GD2, I won't even try with that word, leading to cell lysis via antibody-dependent cytotoxicity and complement-mediated cellular toxicity. This is highly expressed on neuroblastoma cells, most melanomas, and importantly for toxicity purposes, some normal tissues, including neurons and nerve fibers. In that FDA-approved indication for high-risk neuroblastoma, it's 17.5 mg per meter squared per day over 4 days. It's given in combination with GM-CSF, or sargramostim, interleukin-2, as well as isotretinoin. Pre-medications are required for these folks. Again, think about your pediatric population when you consider this. But we're talking about Benadryl pre-medications and then scheduled Benadryl, Tylenol pre-meds, as well as PRNs, a morphine PCA, which has a bolus and a basal throughout the infusion. And then even yesterday, we were looking at a peds patient who had some lidocaine boluses and continuous infusions as part of a clinical trial to help with a lot of this neuropathy that comes with the agent. So black box warnings associated with this product, infusion-related reactions, decently high rate of grade 3 and 4 infusional toxicities. Neuropathy and neurotoxicity, again, pretty high, 6% in folks, but 85% of these folks will have pain associated with that mechanism of action and where those GD2s are located on those neurons and nerve fibers. Capillary leak syndrome, pretty high rate here at 40%. And then hemolytic uremic syndrome and transverse myelitis are also toxicities noted with this product. So it's very interesting from a mechanism perspective, as well as showing those on-target but off-tissue effects that you can see with a lot of these products, and kind of what that might look like in clinical practice. And then we have inotuzumab. Inotuzumab ozogamycin is a CD22 monoclonal antibody conjugated with kalikiamycin, as well as the linker that we always talk about. Kalikiamycin binds to the minor groove of DNA to induce double-strand cleavage and cell cycle arrest. This is FDA approved in the relapse refractory B-cell ALL setting. Dosing is there on the slide. Of course, it requires pre-medication like all of these things do. Black box warnings, again, for hepatotoxicity, including delayed veno-occlusive disease during stem cell transplantation. So folks who have received inotuzumab historically are at a higher rate of that VOD that we've talked about. They also have a higher post-stem cell transplant non-relapse mortality that was demonstrated in clinical trials. And they have significant higher risk for things like increased LFTs and bone marrow failure, which are all, of course, big considerations for this B-cell ALL relapse refractory population. And finally, I wanted to get something a little more novel, moving beyond just your flat mAbs as well as your mAbs that are drug antibody conjugates, moving to the bispecific T-cell engager. The classical example here is blinatumomab, though others are in clinical trials. You can see here that you have two different monoclonal antibodies, an anti-CD3 antibody and an anti-CD19 antibody. And if you put those together and you have a mAb that expresses anti-CD19 and anti-CD3, you get blinatumomab. Blinatumomab is kind of that bispecific or two-directional, and it brings together CD19 with your cancer cell and CD3 with your T cell, bringing those two cells together, leading to T cell proliferation and apoptosis of those malignant cells. So you kind of like stick two different mAbs together, bring those cells together that weren't being brought together by your body, and leading to apoptosis and cell death. Blinatumomab is, again, as we expressed, leads to that cytolytic synapse between those two cells. The dosing that's FDA approved is on the slide here. It's 9 micrograms continuous infusion for 7 days in those folks who are B-cell ALL that's refractory, and then moving on to 28 mics per day continuous infusion thereafter. And there is no ramp up or no 9 microgram ramp up over 7 days for those folks who are MRD positive or have lower burdens of disease. This is a really interesting product from a pharmacist's perspective, of course, because with a slow continuous infusion over several days, these patients go home with these pumps for up to 4 weeks at a time, and it's a really big consideration for not flushing your line, not going to a local hospital and letting folks flush that line, because it has a huge risk of life-threatening cytokine release syndrome. So you don't want to flush those lines with that small amount of drug and deliver several hours worth of drug in a small period of time, leading to things like significant infusion-related reactions or cytokine release syndrome. We also have a black box warning here for neurotoxicity in 65% of our patients. So again, a very high rate of toxicity there. Arrhythmias are relatively common for these folks. So this is kind of one of those drugs that requires hospitalization for initiation and dose ramping, requires pre-medications, of course, for bag changes, as well as logistical issues regarding all the things that we talked about with regard to line maintenance and line flushing, and ensuring that folks who are unaware of the product don't, administer flushes or what have you. That was by no means a comprehensive look at the monoclonal antibodies, but I did want to focus on, again, some of those newer agents or more novel agents that you may only see a couple times a year, but ensure that you've at least seen them before. Now I'm going to move on to immune effector cells, or IECs, and more specifically, chimeric antigen receptor T-cell therapy, or CAR T-cell therapy. As a reminder, or as a refresher, CAR antigen receptors are special receptors created in a laboratory that is designed to bind to certain proteins on cancer cells and are added to T cells to help them find and kill cancer cells that a specific protein expressed on their surface. The classic example is CD19-directed CD19-directed CAR T-cell products, which we're going to talk about. There are at least 3 products that are FDA approved currently, but that is not kind of the limitations for what CAR T products can be. These CAR T products are utilized to try and ensure that the modulated T cells are brought into a patient, that those can go and eradicate a tumor that wasn't initially being eradicated by that person's immune cells. But also, you want to try and have these cells persist. So it's great that they would go in and treat refractory disease, but you want to ensure that they continue to kind of surveil and float around and proliferate within the body, hopefully for months or even years, to prevent relapse or recurrence of a patient's disease. I do like a nice graphical depiction of how CAR T-cell works or how we make it happen. So up in the upper right, you have a patient who undergoes leukapheresis or pheresis of their leukocytes. Those cells are shipped off to typically a manufacturing facility on the West Coast, is what I've seen historically, where those cells are reprogrammed using an inactive virus, such as a lentivirus, where they're encoded to recognize those cancer cells or express a receptor that they weren't expressing at a high rate. After those cells are impregnated with those viral vectors, they are expanded in vivo to try and make as many cells as possible. There is a quality check to ensure that those cells are expressing your CAR receptor that you wanted to express. And then they are shipped back to UW Health, where we give a little bit of chemo, days -5, 4, and 3 prior to cell infusion, just to make a little bit of room. And then you have those cells reinfused to those patients, hopefully leading to cell death and cell kill. Some interesting things that we've kind of learned along the way as CAR T-cell therapy products is that not all patients are going to be able to be leukapheresed or give us enough T-cells to make this a viable process. We know that there are delays in this manufacturing process. It can take 20+ days to go from leukapheresis to infusing cells, or even longer. And there are backups in this process. Not every time when they do the reprogramming of cells are they expressing CAR T-cell receptors to a high enough liking. So a lot of these drug companies say at least 80% of these cells need to express CAR T receptors, or else it's not considered, good enough. And there's actually kind of open clinical trials for what if your patient has these cells manufactured, but they only express 77% of your CARs. Is that good enough? So we have kind of ongoing manufacturer-led trials in that arena as well. So we do have, and then while you're waiting for all of that process to happen after that leukapheresis, sometimes these folks need things like chemotherapy bridging to try and hold their disease in place before these CARs come back to them, because 20+ days without therapy in someone who has, relapse refractory ALL or diffuse large B-cell lymphoma, that's a lot of time to lose disease control potentially. So there's a lot of considerations as part of this CAR T workflow to try and keep things kind of moving along. The CD19 approved products, I have kind of a graphical depiction here on the slide. You have on the left-hand side Tisagen Lec-Lucel, brand name is Kymriah. You have Axicaptogene Silolucel, or brand name Yescarta. And you have Brexacaptogene Autolucel, or Tecartus, as your 3 CD19-directed CAR T-cell products. You can see that they all differ in slight ways. Going down Tisagen Lec-Lucel, the FDA-approved indications are for ALL up to 25 years old, or relapse refractory diffuse large B-cell lymphoma. And the viral vector that's used in the manufacturing process is a lentivirus in this case. And I also like to point out all of them require pre-medication, and you want to try and avoid steroids in these products in a prophylactic setting, because steroids can be directly toxic to CAR T cells. The data is evolving in that setting, but at this point, we try and avoid corticosteroids if possible. I do include, just for your reference, the wholesale acquisition cost, or WAC, of these drugs. You'll see in the bottom, the WACs differ slightly, but they are quite a bit of money. So there's a lot of discussion with regard to sequencing of these products, how to sequence them, how to use them the most efficiently. Do they go pre or post auto or allo, or how do they fit within our treatment paradigm for the disease states that they're approved for? Moving back to Axicaptogene in the middle here, it's again CD19 directed. FDA approval is only in the relapsed and refractory diffuse large B-cell setting, and this uses a retrovirus. And on the far right-hand side, you have Brexacaptogene, which is approved only in the relapsed refractory mantle cell lymphoma setting, and this uses a retrovirus. Moving on, the most recent FDA approval, I believe, is the Idacaptogene Viculucel, or Abecma. This is actually BCMA targeted in, excuse the slide there, not in the relapsed refractory diffuse large B-cell setting, but actually in relapsed or refractory multiple myeloma. As we talked about with the MABs earlier, BCMA is a target for multiple myeloma as it's highly expressed, and we now have a monoclonal antibody that targets that as well. But here we have a CAR T-cell product that targets that BCMA receptor that's highly expressed on multiple myeloma. The problem then becomes, much like in CD19 on the previous slide, since there are some mAbs that are approved against CD19 now as well, is with regard to sequencing in these products. There is a concern for the fact that if you give a mAb against that target, is your CAR T going to be as efficacious or vice versa? There's a lot of discussion and a lot of data that we still need with regard to sequencing of these products, particularly when you're targeting the same receptor via mAb or via CAR T product. The rest of the slide is, as you would expect, they do use a lentivirus for the manufacturing processes of the Abecma product, and the WAC is about $420,000. Efficacy, I would have loved to give you a big table looking at the efficacy of these products and how they might function in a certain disease state, but it all varies very significantly based upon the population that is studied. These products now are approved in the third line setting for relapsed refractory ALL or what have you, but they are of course being studied in earlier phases, or the sequencing is being looked at with regard to these products. So the global question about efficacy is a difficult one to summarize on a slide. I do like this graphical depiction here, though, looking at lymphoma in this patient who received CAR T-cell therapy after several lines of failure of classical chemotherapy. And it shows you kind of the graphical depiction of what you can find in a chemo-refractory patient. But it's really just kind of a graphical depiction to show you that this is something that we can see. Here at UW Health, we are looking at what our efficacy and outcomes look like in these CAR T products. Of course, they're very expensive. They are difficult to manage sometimes. So you really want to kind of have a look at what your efficacy looks like at each site. Toxicities, as you can imagine, they are pretty significant. Starting in the upper right-hand side, we have neurologic toxicities, including confusion, delirium, aphasia, and seizures. One of the more interesting things that we talk about with these products is on-target, off-tumor toxicities. So if you have a CAR T-cell that's targeted against CD19, that's great when it goes after the malignant CD19 B cell, leading to tumor eradication. But what if it wipes out all of your B cells that express CD19, including your normal non-malignant ones? So this is a toxicity that we see in these CAR T products, where you basically have B cell aplasia, or complete eradication of your B cells, and those patients will have to exist without that B cell function for months and hopefully years if these CAR T products continue to persist within your body for months and even years. On the bottom right-hand side, we have anaphylaxis or allergy responses, of course. On the left-hand side, you have cytokine release syndrome, which is depicted by fever, tachycardia, hypotension, capillary leak, organ dysfunction. This is something that we'll talk about here in a little bit. And then there's the potential concern or issue with insertional oncogenesis. You're obviously modulating cells that are infused into the body, so the concern for potential issues with that process is still there, though very, very low, of course. When we're talking about specific toxicities, going a little more in depth about cytokine release syndrome, this is a constellation of inflammatory symptoms resulting from cytokine elevation due to the infusion of these CAR T cells, and also other immune cell responses to cytokines released by these CARs. The severity of CRS in CAR T is associated with the increased level of cytokines, the peak ferritin and CRP levels, the higher blood levels of CAR T cells, as well as higher disease burden, or a larger amount of malignant cells for these CAR Ts to go and proliferate and eradicate. Here's a nice little breakdown via ASTCT and the consensus grading or recommendations here. So you've got grading all the way from grade 1 to grade 4 of they've got a little bit of a fever, not much else going on, all the way to grade 4 of they're febrile, they're requiring multiple vasopressors and requiring positive pressure such as CPAP or intubation and mechanical ventilation. This is a nice example of what to do in those scenarios. Now, every product and every package insert is going to be slightly different, and our CAR T-cell guideline here at UW Health reflects that. But here's a nice graphical depiction of what you could potentially be facing based upon your patient. So a really good example, going all the way from grade 1 to grade 4 is, you're observing these folks, you're ruling out infection, you're starting antimicrobials per, things like the neutropenic fever guideline and giving supportive care, all the way to you're giving things like low-dose vasopressors, you're giving potentially steroids or corticosteroids such as dexamethasone or methylprednisolone, all the way up to tocilizumab, the anti-IL-6 product. I'm just going to do a quick aside since I have a few moments. I'm not sure if anyone knows the historical story of CAR T-cell products and tocilizumab, but back when it was originally being studied at CHOP, Children's Hospital of Philadelphia, the first original patient who received it for ALL actually had significant CRS and ended up intubated on multiple pressors, and they were grabbing these inflammatory cytokine labs throughout the process, and they saw a lot of cytokines that were elevated, which we know about in CAR T CRS, but one of the physicians had a daughter who was being treated for a rheumatologic disorder with tocilizumab, the anti-IL-6 inhibitor, and he happened to be noting that, this patient's IL-6 is going up. I have a mAb that I know about because of my daughter. Maybe we should try that to see if that helps in this process. And they actually found that when they administered tocilizumab, the patient did much better. They were able to wean off pressors. They were able to extubate and et cetera. And I believe the patient is still alive at this point. But it's one of those kind of idiosyncratic or weird ways that we've kind of advanced patient care, just being in the right place, right time. But currently, tocilizumab is kind of one of those classical agents that we will use in this grade 2 or higher cytokine release to help with those inflammatory cascades. Moving on to the other prominent toxicity, again, we're talking about the neurotoxicity. Its nomenclature is the immune effector cell associated neurotoxicity syndrome, which is a mouthful, or ICANS. The proposed mechanisms include, although we're not 100% on this yet, passive cytokine diffusion into the brain, as we've demonstrated high serum IL-6 and IL-15 levels associated with ICANS, as well as trafficking of T cells into the CNS, as CAR T cells have been detected within the CNS in patients who have ICANS. This can present in a variety of ways, everything from a headache and tremor, all the way to lethargy and obtundation, seizures and cerebral edema at the most severe, and it's rare to observe ICANS without concurrent CRS for our patients. Again, I bring you the ASTCT ICANS consensus grading here, looking at, are seizures present? Do we have motor findings? Is there an elevated ICP all the way through the process? And I also include here on the slide for your reference the pediatric grading, because of course these are products that we use at a decent amount in the pediatric population. So I wanted to ensure that you had both of those for your reference. But ASTCT does a really nice job of putting out consensus grading as well as management of these toxicities. So I wanted to make sure that you were aware of those references. ICANS management is typically supportive in nature. You want to treat the elevated intracranial pressure and seizures per your standard of care processes. Tocilizumab is only limited to the use of ICANS management with concurrent CRS, as there is no strong data to support its use in ICANS alone. And in this population, you're particularly using early steroids, as those have been shown to be beneficial for these patients suffering from ICANS. Again, these CAR T-cell products are relatively recent from an FDA approval perspective. They have only 4 products that are FDA approved that I'm aware of at this point, but these are products that are being studied in these disease states as well as many, many other disease states right now. They're being studied in hematologic and solid tumors in just about every setting. So it is something that's going to continue to be more complex. And every agent seems to have kind of a unique profile of what those toxicities look like with regard to onset of CRS, onset of ICANS, duration. All of those sort of toxicities kind of seem to differ in various ways. So it's one of those things that these products will continue to evolve. One of the things that's coming is, in this process currently, you need those patients to be able to give you cells via leukapheresis, There are patients out, or there are clinical trials ongoing for products that are off-the-shelf cells. So if I just donated cells to you or to a general pool, and they could modulate my T cells, that way you wouldn't have to worry about trying to collect T cells off of a patient who's multi-refractory and their marrow's been beat up pretty heavily. So things like that are coming, I think, down the pipeline to make this process a little easier for patients, because you certainly don't want to, produce these cells and then have a patient go through a fulminant relapse and not be able to receive these cells either. So there's a lot of work going on in the background for CAR T-cell therapy, and much more to come in the near future, of course.
Jason?
That's wrap. Yeah,